So myelopathy is a disorder of the spinal cord. So it's any disorder. So the spinal cord, as you know, starts from the base of the brain, and it goes through the canal, through the cervical thoracic spine, and ends at around the first and second lumbar vertebra. And then it forms what we call the chorda equina, which is like a horse's tail. So myelopathy is any disorder which is affecting the spinal cord from where it starts to around L2. And that could be, again, trauma. So somebody having an accident could fracture or dislocate their spine and cause an injury to the spinal cord. It could be infection which can cause some either destruction of the bones, so there's instability and there's movement when there shouldn't be, or because of the infection, it can create like a collection of pus, which is pressing on the spinal cord and causing a pressure effect. You can also get it with tumors, again, similar like infection, causing a pressure effect and affecting the function of the spinal cord. The most common cause that I see in my practice is degenerative. So, and it's very common in the cervical spine, called cervical spondylitic myelopathy. And that's kind of a progression of wear and tear, which effectively leads to compression of the spinal cord, which, as you can appreciate, any compression here is going to be responsible for everything below it. Any compression there in the chest will spare the hands, but will affect everything below it. And then we'll go into the symptoms a bit later on. So basically, it's one of those things that patients may not be aware that they have myelopathy. They tend to be referred to me for other reasons, and I tend to pick it up. Or they present with different features, and then an MRI scan is arranged, and that picks up compression of the spinal cord, and then they come and see me. So the salient questions that I would ask my patients would be, so if the compression is here on the spinal cord, the most important thing is it's going to affect your hands, okay? So I'm going to ask you, are your hands clumsy? So normally we do buttons and we do zips without thinking about it. But somebody with myelopathy, with compression here, will struggle. It will be clumsy and they just can't do it. They lack the dexterity. And they may choose to wear clothes that don't have a button or a zip. They may choose to put slip-on shoes so that they don't have to tie up laces. Or if they're trying to pick up an object off the table, they may lack that sort of pincer and may prefer to push things into their palm. And they'll probably put it down to, oh, I'm getting older and it's arthritis. But actually, it's the patient's not going to realize, and it's kind of something that I will pick up. Another thing is that their handwriting may change. They may obviously get some pain, but that's not always there in the arms. Another important thing is their walking. So somebody with myelopathy, whether it's compression in the neck or in the chest, will affect their ability to walk. So people may say they're walking drunk, or they can't walk in a straight line, you know. Or, for example, if you're getting up to go to the toilet at night, can you find your way to the dark? Or do you have to hold on to furniture or put lights on? And that's important because somebody will say, well, I was always able to do it, but more recently, I just haven't been able to. One of my patients, her husband had to put bubble wrap on the furniture because she kept falling over and cutting herself. And again, I don't think it's things that patients themselves would come and tell me, but it's something that I need to sort of tease out of them. The last thing is sort of control of bladder and bowel, knowing when you have to go to the toilet. So obviously, if something comes out without you knowing, or there's numbness, that's a bad sign. But that's very late, and I don't routinely see that. So the cause is basically anything that causes compression or anything, even inflammatory conditions that aren't compressive, like multiple sclerosis or many neurological conditions can cause this. So anything that stops the spinal cord from working properly can do this, whether it's inflammation, infection, cancer, wear and tear, or trauma, or even surgery. Somebody doing surgery, God forbid. When I do this type of surgery, I use spinal cord monitoring. So it's almost like having a co-pilot telling me that the nerves are all okay whilst I'm doing the operation. So I get sort of further feedback. But yeah, there are many causes, and it's sometimes not always clear. Many times this needs a multidisciplinary team approach where we discuss this with colleagues, radiologists, neurologists, to bespoke the treatment to that individual. So it can be quite serious. So I mean, if there is an MRI confirming that there's pressure on the spinal cord, and I ask questions and do an examination and it all matches, then I would basically say I would advise that we do surgery. So left alone, if I leave somebody with confirmed myelopathy, with almost certainty, I could say that the condition will deteriorate. But I don't know when, and I don't know how much. So the purpose of intervening is to prevent further deterioration and to preserve neurological function. So to preserve dexterity, balance, gait, bladder and bowel control. Some people may have had it for so long and don't want to do anything about it that they start getting weak and they start losing that dependence. And even though there may be a very small proportion of patients who may continue to get worse despite treatment, the majority of patients, we will manage to halt the progression in the hope that they can improve. So I suppose it comes back to what the cause is. So if it's infection, treat the infection with antibiotics, maybe surgery. If there's a fracture, reduce the spine, stabilize the fracture. If it's tumor, I don't deal with tumors, but it would be to speak to a center that deals with the tumors and remove the tumor either through surgery, radiotherapy, chemotherapy. So the type that I see because of degenerative disease, the cure is very much tailored to the patient. So if the patient doesn't have any symptoms and doesn't have an abnormal neurological examination, but only has an MRI showing that there's pressure, I won't advocate surgery, but that depends on the functionality of the individual. So if that person says, I'm a professional boxer, I'm a paraglider, I'm a horse rider, and I will not stop, that individual has a risk of falling and has a risk of damaging the spinal cord, which is already compromised. So even though they don't have symptoms and the examination is normal, I would then encourage that person to have surgery, either through the front of the neck or the back of the neck, to prevent progression. But again, there are some patients who they're quite old and frail and low functional demand. And for them, the trauma of surgery may be a greater risk than the benefit of doing that. They may have been like this for decades, but the fact is that I've picked it up. So there's no right answer or an answer that fits everybody. It is very much about bespoking the treatment to that patient. It can be treated, but I cannot guarantee that any function loss can be regained. That can sometimes take years to show itself.